Yes. Surgery. Yes, sorry, let's see one of the what they would generally look.
Yes. Sir, ma'am is not picking up the phone. Simran. Good morning, everyone. Today I am here to present my seminar on the topic of respiratory examination, and my moderator is Dr. Shobit Garg sir. We will study respiratory system examination under the following headings, that is inspection, palpation, percussion, and auscultation. Inspection. Explain the procedure to the patient and ask permission. Ensure proper lighting and adequate exposure and position of the patient. On its
Step by step you show, or then you what is your plan?
Sir, I will demonstrate it here. Inspection for symmetry of chest. Normal chest is symmetrical and elliptical in cross section. Normal anteroposterior to transverse diameter ratio, that is the Hutchinson index, is 5:7 in normal people. The normal subcostal angle is 90 degrees. It is more acute in males than in females. Abnormalities of the shape of the chest. Barrel-shaped chest is due to chronically overinflated lungs. In this, transfers to AP diameter becomes equal and supraclavicular fossa are full. A barrel-shaped chest is seen in case of the COPD. Abnormalities of the shape of the chest. Pectus carinatum, which is also known as the pigeon-shaped chest. In this, breastbone is pushed out. In the case of pectus excavatum, cobbler's chest, breastbone is pushed in. Causes of the pectus carinatum are rickets, severe asthma, Edwards syndrome, Down syndrome, Marfan syndrome, homocystinuria, and osteogenesis imperfecta. Causes of pectus excavatum are rickets, Marfan syndrome, scoliosis, and Ehlers-Danlos syndrome. Now we will inspect the back. We will look for the drooping of the shoulder undue prominence of the medial border of the scapula, and the level of the inferior angle of the scapula. We will look for the shape of the vertebral column and intercostal spaces from both the sides. Normally, cervical and lumbar spine have lordosis, and thoracic and sacral spine have kyphosis. Exaggerated forward rounding of the back is known as the kyphosis, and inward curve of the lumbar spine is known as the lordosis, and sideways curvature of the spine is known as the scoliosis. We can also look for the tracheal position with the help of the trail sign, that is due to undue prominence of the clavicular head of the sternocleidomastoid on the side to which trachea is deviated. Respiration. Inspiration is an active process and is done with the help of external intercostal muscle and diaphragm. Expiration is a passive process. Accessory muscles used are in inspiration sternocleidomastoid muscles and scaling muscles, and in expiration internal and innermost intercostal muscles are used. So, ma'am, good morning, ma'am. Good morning, ma'am. Hello. Type of respiration normally are thoraco-abdominal and abdominothoracic. On the basis of rate, there is tachypnea, which is known as the more than 22 breaths per minute, and bradypnea, less than 16 breaths per minute. Apnea is the cessation of breathing for 10 seconds or longer. We can also look for the distended neck veins and dilated superficial veins over the chest in case of superior vena cava obstruction. We can look for the various scar marks, which can tell us about the previous surgical history of the patient. On palpation, we have to confirm the findings of inspection. First of all, we have to wash and warm our hands. Compare both sides with adequate exposure and proper positioning of the patient. We can look for the tracheal deviation by making the patient to lie in supine position or in sitting position with neck slightly extended. Either keep the index finger in the suprasternal notch and compare the distance on the either side, or place the middle finger in the notch and check whether the index finger and the ring fingers placed on the sternocleidomastoid muscle are equidistant to it or not. Causes of the tracheal deviation can be toward the side of the lung lesion, lung collapse, upper lobe fibrosis, and pneumonectomy. Away from the side of the lung lesions can be tension pneumothorax and massive pleural effusion. We can look for the chest expansion by putting our both the thumbs below the sternum and wrapping our hands around the inframammary area, and it should be bilaterally symmetrical. It is normally around 5 to 8 centimeters. Chest expansion can be restricted due to generalized causes like emphysema, bilateral fibrosis, bilateral pleural effusion. Chest expansion.
Welcome, ma'am. So we would like to welcome Dr. Ma'am. She doesn't need any introduction. Yes, flexibility we have. Now we have actually started this at the request of postgraduates. So ma'am, he is just on the he's finished the inspection part.
We can look for the chest expansion by putting both the thumbs of our hand below the sternum and wrapping our hands around the inframammary area, and it should be bilaterally symmetrical, and it is normally around 5 to 8 centimeters. Chest expansion can be restricted due to generalized causes like emphysema, bilateral fibrosis, bilateral pleural effusion, ankylosing spondylitis, bilateral pleurisy, and neuromuscular disorder. Restriction on the one side can be due to pleural effusion, lung or lobar collapse, pneumothorax, or unilateral fibrosis. Apex beat. Apex beat can be localized in the fifth intercostal space, 1.5 centimeter medial to the mid-clavicular line. Here is a video depicting how to detect the apex beam. Apex beat can be displaced to the left side due to lung collapse of the same side, that is left side, or due to right side effusion or right side pneumothorax. Displacement of the apex beat to the right side can be due to lung collapse to the same side, that is the right side, or left side effusion or left side pneumothorax. Cricosternal distance is the distance between the cricoid and the sternum, and it is usually 3/4 finger, and it is decreased in the case of the COPD. Vocal phrenitis, tactile vocal phrenitis is low frequency portion of vocal spectrum that radiates to the chest, and it is palpated by the ulnar border of our hand. सर इसमें चल नहीं गया सर, मैंने किया सर.
इससे पहले वाला स्लाइड दिखाया था
Yes.
डिस्टेंस का.
Yes ma'am.
इसमें डिस्टेंस आपको बताना होगा कि कितना डिस्टेंस होता है. हाउ मेनी फिंगर्स, 2 to 3 fingers usually.
Yes ma'am. 3/4.
3 to 4 fingers.
Yes ma'am.
It decreases in COPD,
Yes ma'am.
and if patient takes respiration, deep inspiration, it seems that it is pulling inside the patient respiration लेते हैं, तो ऐसा लगता है कि अंदर खींच रहा है because of the barrel shaped chest and COPD में. It is
Yes.
called tracheal tub.
Yes.
And stop share. Let's see whether it's focus working. Focus check up, stop share.
And you can, sir.
Right.
And you can.
And we can